Okay, so hi, I'm Maryam, one of the registrars at Brighton. If I can ask everyone to put on their cameras, unless you're dead against it, that's fine. But if you can put in your camera, because what we're going to do is try and make this as interactive as possible. So we'll be asking questions, so please volunteer. Okay, so what we're going to be covering today is basic fracture management. And essentially, we're going to be looking at 4 R's of fracture management. And then tying on to that is teaching you guys how to recognize and initiate basic management of fractures. And also to gain a basic understanding of what is a stable fracture and an unstable fracture, and when you would need to operate. To understand the difference between pediatric and adult fracture managements, and we'll go into a bit more detail into types of pediatric fractures. And tying into all of that is when you call for senior assistance. Okay, so we'll kick straight off. If you have any questions, as this is interactive, just ask straight away, or you can just post on the chat and we'll keep an eye on that. Okay. So with any suspected fracture or confirmed fracture, you start with a history, basic history and examination. I'll go through this very briefly because we'll have a session on this later. So with a history, you ask patients who, what, when, where and why. So who they are, basic demographics, age, what happened, when did the injury occur, what part of the body is injured, and the situation arising to that. You then go into your systems review. So in particular for orthopedics, you ask about pain and stiffness and swelling, whether they can wait there through that limb or use that limb. And very importantly, you do need to ask about neurology. So in particular, do they have weakness, numbness, or paresthesia? And then you go through your basic history in terms of past medical history, drugs, and social history. You then move on to your examination, and with any orthopedic examination, it's very basic: look, feel, move. Those are 3 things you need to know, the 3 things you need to remember. So with look, the first thing is this limb or fracture open or closed? Because that does change your management. Is there any swelling or deformities, any surrounding redness? And then you move on to feel. So feel for your bony landmarks, and particularly whether it's causing pain. And then you move on to your movement. So basic flexion, extension, depending on what type of joint there is, rotation. Always remember to assess the neurovascular supply. So neurology and your distal pulse is very, very important, particularly with someone who has major trauma, and always examine the joint above and below. Then move on to basic investigations. As with every other patient, you start off with your baseline bloods. It's always a good idea to include clotting and group and save in case the patient needs to go to theatre. Depending on their age and the other symptoms, the patient may need to do a chest x-ray. But more importantly for us, for orthopedics, we need basic x-ray. So with x-rays, we need 2 views, an AP view, which is an anterior posterior view, and a lateral view of the affected limb. Ideally, you'd like to include the joint above and below, but sometimes that's not feasible. So you can just request that as a separate x-ray. And depending on the injury, depending on how bad the injury is and what kind of trauma it is, you may want further investigations like a CT or an angiogram. So moving on to 4 R's of fracture management. Can anyone tell me what I mean by resuscitate? So you have your patient, it's either a minor trauma, major trauma. What do I mean by resuscitate? Anyone at all?
Analgesia, fluid management.
Yeah, so with your resuscitate, you start off with sort of your basic ATLS, which is your advanced trauma life support principles. Okay, particularly with the major trauma, to assess the airway, you go through your ABCDE. Okay, so good. And then what do I mean by reduce? So you've done that, you've stabilized the patient, you then you realize that there's a fracture there. What do I mean by reduce?
I think you just realign it to normal anatomical sort of parameters.
Exactly. So if you think the fracture is displaced, or if it's confirmed on an X-ray, you want to realign that fracture. And I'll go into in a second a bit more detail about each of these 4 R's. Restrict. What do I mean by restrict? No. So restrict is essentially immobilizing the fracture. Okay, we're going to do so in a second. Rehabilitation is getting the patient going, essentially, and physiotherapy. So let's go into a bit more detail in 4 Rs. So first of all, resuscitate. So you assess the patient following the ABCD protocol. If there's a major trauma, you follow your ATLS protocol, which is very similar, and you essentially treat life-threatening injuries first. That could be a head injury, chest injury, abdominal injury. So all those injuries get treated first, and then you move on to the limb. Sometimes the limb itself is a life-threatening injury, for example, an operofemoral fracture, and they're bleeding and bleeding and bleeding. So that is a life-threatening injury. And you look for other injuries. So don't just be so fixated on the bone itself, particularly with a major trauma. There could be other things going on. So for example, the C-spine, if it's a road traffic accident, does the patient need the C-spine immobilized due to the immobilization? So always look out for other injuries. Moving on to reduce. So you reduce a fracture if it's displaced. Okay, so if the 2 bones are not touching or at an angle or not in their anatomical alignment, you want to reduce this. And there's 3 ways you can do that. So the first one is close reduction. And that can be done pretty much anywhere. You can do it in clinic, on the ward, in the emergency department, in theatre, under anaesthetic. Okay, the next one is open reduction. So that's actually physically visualizing that fracture and reducing it. Okay, and open reduction is more commonly used for intra-articular fractures or if there's any sort of underlying neurovascular damage. The other type of reduction is traction. So traction, again, quite similar to closed reduction. You want to align the bones and you want to keep those bones in that fixed position for a period of time. Collar and cuff is a type of traction. You can have skin traction. You can have traction splints, or you can have skeletal traction where you have pins actually going through the bone and then weights coming off that. Restrict. So once you've reduced the fracture, you then want to restrict movement at the fracture site. So you don't want that fracture moving to allow healing. Okay, and there's a few ways you can do that. A lot of patients can just be restricted and immobilized conservatively. So that can either be through a cast, either a full cast or a back slab, through a brace, through traction, which I've just covered, or sometimes if it's completely undisplaced and it's a small fracture, sometimes you don't need anything. If conservative immobilization is not an option, you then move on to operative route. So internal fixation is one type of mode of restriction, and that's more commonly used in comminuted fractures or displaced fractures or fractures going into the joint. So anything you cannot reduce or immobilize conservatively, you then do operatively. And there's 2 ways of doing that, either intramedullary, so that's, for example, nails going through the bone, or extramedullary, like plates and screws or external fixation. And that moves on to external fixation, which is a frame. And we'll go through all these different methods a little bit later. So a frame outside the body. Moving on to rehabilitation. So after you have resuscitated the patient is now stable, you reduced the fracture and restricted them either conservatively or surgically, you then want to start the rehabilitation process. So that could be through exercises that you give them or a physiotherapist gives them. And the aim of this is to regain function. Depending on where the fracture is, it's very important to consider the weight-bearing status of whether they can put complete weight through it. That's usually after intramedullary nails or joint replacements, of whether you want to restrict their weight bearing. And most importantly, fractures are really, really painful. Okay, so do not be afraid to give pain relief. IV paracetamol and even IV morphine in the ED setting is completely acceptable. Some patients do need a bit of Gasanel, Penthrox, particularly when you're reducing a fracture. Definitely give them something. You can give blocks, so a hematoma block, ring block, or nerve blocks can be given, again, when you're reducing a fracture to help with pain relief. And the best form of pain relief is actually the reduction itself, okay, and elevation to help with swelling. So I'm just going to now go through different types of fractures, and I will be asking questions. So
could I just ask a quick question on the pain?
Of course. Yeah, of course.
So sometimes patients, they'll be on like 4 to 6 hourly oxynorm and still complaining of pain.
Mhm.
Can I give more than that?
You can. So if they are still complaining of pain, you need to actually go and assess the patient. And you need to know where the fracture is. Is it close? So if, for example, it's a tibial fracture, it's a closed tibial fracture, what would you be worried
Oh, I'm
about?
talking about something that's set. Like sometimes I'd have patients here and they'd have like a hip replaced or something like that, or
Yeah.
and they're on dancetrone, oxynorm, and like I don't feel comfortable giving anymore.
Okay.
They're still in pain. What?
Yeah. So essentially, you would follow your analgesic ladder. So they're on oxygen, but make sure they also have paracetamol going, plus or minus dihydrocodeine or codeine. You can give more oxynorm depending on their body weight and their renal function. If you're completely not comfortable, then the best thing is to speak to a senior or even the med-reg.
Okay, thank you.
All right, so let's start with ankle fractures. So typical history with ankle fractures is a twisting injury to the ankle. So either they've tripped over something or they've fallen from some steps or stairs, but it's a twisting injury to the ankle, okay? On examination, they cannot put weight through that ankle. The ankle is typically swollen. Sometimes there may be some sort of deformity, and it's quite obvious it's an ankle fracture. When you're examining, very important to know whether there's an open and closed injury, as with any other joint and bone, and to assess the neurovascular status of your distal pulses, in particular your posterior tibial and your dorsalis pedis. Now, before I go into types of ankle fractures, it's very important to know, and I'm sure some of you may have already covered this before, but very quickly, what a normal ankle looks like. Okay, so these are 3 different views of an ankle joint, and this is what a normal ankle looks like. So you have your talus, you have your fibula with your lateral malleolus. You just follow my cursor. You've got your tibial plafond, and you've got a nice joint space going across, and then you've got your medial malleolus there. And essentially, the gap between these 3 bones is pretty much equal, okay? And then the lateral, your tibia sitting quite nicely on the talus, so it's not tilted anteriorly, it's not tilted posteriorly. So this is what a normal ankle looks like. Can someone please describe what they see here?
Yeah, I can have a go.
Yep.
So I'd say there's a complete transverse fracture of the distal fibula beneath the syndesmosis.
Good, excellent, well done. This one?
Is that a Weber A fracture?
The first one is a Weber A, and we'll go through classification in a second. What's the middle one?
Weber B?
Exactly, yep. So you've got
at the level of the syndesmosis.
Exactly, yep. So the fracture lands at the level of the syndesmosis and the oblique fracture of the distal fibula. Good.
That's Weber C.
Excellent, yep. So it's above the level of the syndesmosis. Good. Okay. What's this one? Just describe what you see.
It's displaced, significantly displaced. Yeah, fracture dislocation.
Exactly. So this is a fracture dislocation. Bad sign. Yeah. Good. So very quickly going through classification. So as you very correctly described, the most common classification of ankle fractures is the Weber classification, split into A, B, C. So as you can see in these pictures, Weber A is a fracture line below the level of syndesmosis. So if you follow my cursor, syndesmosis is a big area sort of sitting around here. So that's below the level of the syndesmosis. Weber B is at the level of the syndesmosis, and then C is above the level of the syndesmosis. And it's quite important to know this classification because it does help you determine what kind of management this patient will have. So for Weber A, the ankle is relatively stable, so they can actually go into a walking boot and start walking through that ankle. We then follow them up in fracture clinic, and we do X-ray them just to make sure that nothing is displacing. Weber B, what do I mean by talar shift?
Whether or not the talus has moved.
Yeah, essentially. So if you have a Weber fracture, which is at the level of the syndesmosis, and the joints are going over your talus, so between your talus, your fibula, and your distal tibia, looks pretty much equal. Therefore, you don't think there's a talus shift. Again, the patient can go into a walking boot. Again, we follow these up in fracture clinic. We do check x-rays because sometimes these fractures can displace and they do present themselves. Weber B with talus shift needs reduction. Okay, you want to restrict the movement at the fracture site. So we usually place them into a below knee back slab, which is something like this in this picture here. And then after we put them into a back slab, we check the x-ray just to make sure that intervention hasn't caused the fracture to move further. These fractures do swell. So it's very important to tell the patient to elevate it. And once the swelling has come down, or if the swelling isn't very bad in the first place, we then go on to fix these fractures. And Weber C, so that's above the level of the syndesmosis. So that essentially means it's an unstable fracture. Most likely your syndesmotic ligaments have gone. That fracture needs reducing, very similar to a Weber B, needs to go into a below knee back slab, repeat an x-ray, elevate them, and then plan for a fixation. If it's an open fracture, initially what you'd want to do is follow sort of your open fracture guidelines, which is give them antibiotics, give them tetanus. You want to treat the wounds. You're not just treating the fracture, you're also treating the soft tissues. Okay, so depending on how bad the open wound is, wound washout, debridement, and then plan for fixation. And as I mentioned earlier, if the patient is too swollen and is still dislocated, which is confirmed on an x-ray, the best way to keep that ankle in a stable position is to do an external fixation. Sometimes we do have patients who have very unstable ankles that are still unstable in the back slab. So therefore you would do an external fixation, allow the swelling to come down, and then plan for your definitive fixation. Can someone describe to me what they see here?
It's a previous bimalleolar fracture, which is fixed with 2 syndesmotic screws and a long plate on the fibula.
Yeah, so you can see here, if you follow my cursor, so this is your fracture line of the fibula. Okay, how do I know that? Well, you can see a bit of displacement here, and they've got a lag screw going across. So it's a Weber C fracture, and as you correctly said, you've got a fibular plate, you've got 1 syndesmotic screw going across, and then assuming here there was a medial malleolus fracture, so they've got screws fixing that as well. Quite similar here again, you've got screws going into the medial malleolus, and you've got a nice long fibular plate fixing the distal fibula. Good. So this is an example of an external fixation. Okay, there's so many different types of external fixations. You can make different frames, have circular frames. It just depends on soft tissues and the fracture. And essentially what you want to do is you want to reduce this. So for example, something like this fracture dislocation, which may be open, will most likely require an external fixation because this patient will be very swollen and unstable. And so a frame like this will keep the ankle in place and allow that swelling to come down. Any questions on ankle fractures before we move on? No? Okay, so hip fractures. Yeah.
Sorry, I didn't have a question on ankle fractures specifically, but in general, when you're trying to reduce a fracture, do you always try to do closed reduction before you do open reduction? And how do you know whether or not to use, for example, a hematoma block, or I don't really know the difference, but like, let's say IV morphine or something? How do you know which medication to use for that specific pain management?
Okay, so with all fractures, you work up your analgesic ladder, depending on where the fracture is. Some fractures are more painful than others, and patients tolerate pain in different ways. So most patients get IV paracetamol. A lot of them do get IV morphine as well. In terms of reducing, so anything that, even with open fractures, with a fracture open or closed, obviously you look at the x-ray, and you attempt to close reduction. So whatever you see on the x-ray, you do the opposite of that. So if it's quite displaced, if it's minimally displaced or undisplaced, you don't really need to do anything. But if it is quite displaced, you want to try and get it back to normal alignment as close as possible. Okay. For that, the pain relief that you need to give usually from experience, IV morphine and simple analgesia will not work because the patient's in a lot of pain and they end up fighting you. So things like Entonox or Penthrox does sometimes work well. I personally find, particularly with long bone fractures and ankle fractures, they do require a bit of sedation, which can be done in resus in A&E. So that's where your ED or your anaesthetist come down and they give you a hand with sedation. And then you reduce them that way. In terms of determining whether they need an open reduction, again, it really does depend on the fracture. So if it's displaced, if it's unstable, you do a closed reduction to try and immobilize it and get it back to normal alignment, and then you plan for an open reduction in internal fixation.
Okay, thank you.
Does that answer your question?
Yeah, that's perfect. Thank you.
Right, so moving on to hip fractures. Hip fractures are more common in the elderly. Elderly, old, frail patients who have multiple comorbidities, not very good on their feet, and they have sort of low energy trauma and land on their hip. Hip fractures in young patients is due to high energy mechanisms, so fall from a huge height, road traffic accident, those type of mechanisms. And these patients, when they have hip fractures, it's very, very painful, but cannot weight bear through that leg. So you take your normal standard history, particularly for older patients. It's very important for us to know their pre-injury mobility, what kind of house or flat or bungalow they live in, if they're using stairs, if they're using any mobility aids, because that will kind of determine your management. Okay. On examination for hip fractures, typically you see the affected leg is shortened and externally rotated, and they just cannot move that leg. It is just too painful. They cannot straight leg raise. They cannot put any weight through it. When you put axial loading through that leg, it's very, very painful. Okay. So to confirm a hip fracture, we need two views, as with any other bone, an AP and a lateral. So an AP of the pelvis and a lateral of the hip, of the fractured hip. I've put a chest X-ray to rule out chest sepsis if symptomatic. So a lot of patients, older patients, they have other symptoms that then lead them to have a fall, unless it's a mechanical fall, a simple trickling fall. So it's very important, particularly with elderly patients, to look at them as a whole and to examine this systemically. So with hip fractures, I'm sure most of you know this and I've covered this, so very briefly, the most common classification is Garden classification, split into 1, 2, 3, and 4. So Garden 1 is your minimally displaced or undisplaced fractures, usually valgus impacted. Garden 2 can be incomplete or complete fractures, but they are very minimally displaced. Garden 3 are your partially displaced, and Garden 4, the two bones are no longer connecting, so complete displacement. Okay. This classification is very useful because again, it does determine management, alongside patient history as well. Alongside the classification, you want to know where the fracture is. Most importantly, what you need to know is an intracapsular fracture, so anything above the intertrochanteric line, where my cursor is, or is it an extracapsular fracture, so anything below the intertrochanteric line, because that does change your management. Okay. Important to know the femoral head blood supply. Does anybody know why, and how does that determine your management?
If you've got an intracapsular fracture, you can end up with necrosis of the femoral head, because the blood supply from the lateral circumflex and the medial circumflex can get disrupted. So then you'd want to do a complete hip replacement or a hemiarthroplasty. If it was extracapsular, then the blood supply wouldn't be affected, so you could fix the hip with sort of like a screw or something.
Excellent, well done. Yeah, exactly that. So your blood supply coming down from your profunda and your femoral artery, and it goes back up supplying the femoral head. So exactly as you said, anything intracapsular, you're at risk of tearing all these little vessels. Okay, so therefore you're at higher risk of getting avascular necrosis of the femoral head, which essentially means you most likely need to replace anything below the intertrochanteric line. As you correctly said, the blood supply is probably preserved, and therefore the femoral head is spared, and you can just go for a standard fixation. So management, as I said earlier, you need to manage the patient as a whole. These patients are usually elderly. So For elderly patients, we have across the country hip fracture pathway. So you give them analgesia and they get a fascia iliaca block in ED. You need to do all your basic bloods, including group and saves, plus or minus a chest X-ray, and all patients need an ECG. Exclude any other causes that have led them to a fall. So infection anywhere in the body, usually chest or urinary infection. Start them on DVT prophylaxis, usually Clexane, and keep them nearby mouth for theatre the following day. For our elderly patients, we also have across the country orthogeriatric support as well. So these are our medics that specialise in orthogeries, and they're very good at working patients up. So management. So this is sort of quite a simplified version of what you would do. So intracapsular neck femur fractures. If the patient is young and they're fit and active, you want to preserve bone. You don't want to be getting rid of any bone. So your aim is to preserve that femoral head. So you will just fix it with screws. If they go on to develop necrosis, that's fine. At least you've given them a chance to heal, and you've given them a chance to keep their own femoral head. But you'd ideally, keeping your own bone is always better. Okay. If the patient is old and frail and not very active, you go down the hemiarthroplasty route, so that's half a hip replacement. If they're old but they've got good mobility, so they were walking unaided or they were driving before the injury, then you give them a total hip replacement. Okay, so that's just a rundown of intracapsular fractures. For extracapsular fractures, you can either fix them with a nail or plate and screws. So this is a patient who's over the age of 65. They've got intracapsular right neck femur fracture, but physiologically they're old. So by that I mean they most likely have multiple comorbidities. Mobility wasn't great in the first place, so they would warrant for a hemiarthroplasty. And what you can see here is a hemiarthroplasty. So they have their own acetabulum. Do not replace that, but we replace the femoral head and give them a new stem. Someone who is older, but they're physiologically young, so meaning they may not have many comorbidities, they're active. Prior to the injury, they were walking absolutely fine, or they were driving, they may or may not still be working. Give them a total hip replacement because they're still using that joint pretty well. If you give them a hemiarthroplasty, they're at risk of wearing out the acetabulum, meaning that they will eventually need a total hip replacement. So you prevent that, cut out the middle step and go straight to a total hip replacement. So what you can see here is these faint lines, that's your acetabular cup, your femoral head, and then your stem. And this is cemented. You can see cement all around the stem there. Extracapsular fractures. So on the left side here is a relatively underspaced intertrochanteric neck femur fracture. With something like this, you can fix them with a DHS, and this is what you can see on the right here. So you've got your DHS plate, which is a 4-hole plate, and you've got your DHS screw there. With slightly more complex fractures, you can give them a nail. So this is a short intramedullary nail. We also do long intramedullary nails as well. And there's different types of nails, which you don't need to worry about at this stage. Any questions on hip fractures? No? Okay. So move on to femoral fractures. Can someone describe what they can see here?
Mid-shaft femoral fracture.
Yeah. Bit more? Is it displaced, undisplaced? Is it transverse, spiral?
The first one looks transverse, so it kind of maybe a twisting mechanism. And the third one on the right is significantly displaced, whereas the other two are mild or moderately displaced.
Yeah. So both are actually quite displaced. Obviously, the one on the right is significantly displaced and is angulated. Yeah, excellent. So femoral fractures, the femur is a big bone. It's a very, very strong bone. To break that requires a huge amount of energy, or you have an underlying pathology, for example, METs, so cancer and bony METs, which weakens the bone. So usually these are high energy mechanisms. So with your 4Rs, you start off with resuscitate. Okay, so you do your ATLS, your ATE assessment, make sure they do not have any other injuries. You then want to reduce this. Here what you can see on this mannequin is a type of splint. So that fracture has been reduced, most likely in a paramedic setting, so outside the hospital, and it's in this type of splint. Remember, you're managing the patient as a whole. Okay, so again, you want to take your basic bloods, group and saves, give them plenty of pain relief. Femoral fractures are very, very painful. So again, work up your analgesic bladder, IV paracetamol, going up to morphine regularly. Okay. And although it may be clinically obvious that the patient has a femoral fracture, obviously you always need to confirm this on an X-ray. So remember your two views, AP and lateral. You want to examine the patient. You want to know whether there's an open or closed fracture. That does make a difference in terms of your management. You want to know what the vascular supply is distally. Okay, so again, check for your pulses distally. Also assess the nerves distally as well. All right. With femoral fractures, if they're displaced and if the patient is young or relatively immobile, you want to fix them. You can either fix them with a nail, you can fix them with plate and screws. Femoral fractures tend to bleed a lot, and a lot of people do not appreciate this. It's a big bone. It's a massive, massive bone, and patients can very easily lose 1 to 2 liters of blood. So they do need aggressive resuscitation and reduction of that ankle, femur, sorry. And fat embolism. Can anyone tell me why or how a fat embolism occurs in a fracture, particularly a long bone fracture?
Is it something to do with the bone marrow?
Yeah, exactly. So you break a bone, you have fat globules that release from the bone marrow, go into the venous system, back to the right heart, go to the lungs for reoxygenation, and get a fat embolism. Okay. So patients are at high risk. That risk has been reduced over sort of 20, 30 years because we are quite aggressive in surgically managing these patients, reducing these fractures. But you just need to be aware. So as I said, these fractures can be fixed in one of two ways. These are the most common ways. So you can either fix them with a nail, so this is an intramedullary nail. Fractures you can see were sort of between mid to distal third of the femur, and all this sort of bone healing occurring. On the right, sorry, you've got a comminuted fracture. It's like a spiral in a few bits and pieces. So a nail wouldn't be appropriate to something like this. This is where you would use plates and screws. Any questions on femoral fractures?
I had a question which isn't directly related to the femoral fracture, but it's what was on the slide. What exactly is the difference between like a group and save and a cross match? Because I always just hear them. I don't actually know what they are.
Yeah, so group and save essentially, you're sending off blood sample in case a patient needs blood later on down the line. Everything's on the system. For a cross match, you're particularly asking for blood products. So you're cross matching for 2 units of blood or 2 units of platelets, a lot along those lines.
Okay, thank you.
Okay, moving on to tibular and fibular fractures, so working our way down. So tibular and fibular fractures can be low energy or they can be high energy. So in an elderly patient, again, a simple trip and a fall can cause a tibular fracture, whether that's a proximal, middle, or distal. In younger patients, it's usually high energy trauma. Okay, so it's either direct impact or is part of, for example, like an RTC. So again, as I've been saying before, it's very important. So resuscitation. Okay, go through your ATLS protocol, give them analgesia, take some baseline bloods, assess the limb that's affected. Is it open or closed? Reduce that fracture. So again, inline traction, you want to align those bones together. Whether you put them into a back slab or a splint, either or, it doesn't matter. These fractures are very, very painful, and patients do swell, like with any other fractures, a strict elevation. And again, depending on the type of patient, usually we go and fix these. Unless the patient is very, very ill or they're very, very old, extremely low demand, you can manage them conservatively. Otherwise, you do an open reduction internal fixation. What is compartment syndrome?
when you get a rise in intracompartmental pressure, and all the muscles basically become very tense, causing constriction of the compartment. And then I think you can measure it, the intracompartmental pressure, and based on that, you can do a fasciotomy.
Exactly. Yeah, perfect. So yes, a rise in interstitial pressure in an osteofascial compartment, which then causes microvascular compromise, and it is an orthopedic emergency. What are the symptoms of compartment syndrome?
I think it's the 5 Ps, so pain, pallor, perishingly cold, pain on passive movement. I can't remember the last one.
Yeah, pulseless, paralysis. Yeah, excellent. Compartment syndrome occurs, it can occur in any bone, any sort of limb. The lower limb is more common than the upper limb. But tibial fractures have a higher risk of compartment syndrome because of their sort of small osteofascial compartments. So very, very important to look out for those signs and symptoms, because these patients do need urgent fasciotomies and decompression.
Sorry, what's the test that you do to confirm compartment syndrome?
So compartment syndrome is actually technically a clinical diagnosis. Okay, so usually they have an underlying trauma. Usually it's a broken bone. It can be a soft tissue injury of the limb. That affected limb becomes quite woody and quite hard and very swollen in comparison to the other limb, and they're in huge amounts of pain. No matter what you give them, they're just in huge amounts of pain, and particularly when you test passive movement. So for example, if we're looking at these x-rays, if you assume that this person has compartment syndrome of the lower leg, if you start moving their ankle or their big toe, it hurts, they scream. And then you go through 6 Ps. Now, the main symptom of compartment syndrome is pain, 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 and pain. If you're going into a pale leg, pulseless leg, you're going into late stages of compartment syndrome. So usually it's a clinical diagnosis, and a lot of centres don't have compartment pressure monitoring, which is a special device that you insert into the compartment pressures, and it gives you a number. So it's a clinical diagnosis.
Thank you.
Is it true that they say the pain is significantly out of proportion to what it should be?
Yeah.
Is that an early sign rather than a late sign?
That's an early sign. Yeah, absolutely. Okay. All right. So for tibia and fibular fractures, your management, again, it's pretty straightforward, really. You either nail it or you put in some plates and screws. It depends on where it is. It depends on how displaced it is, whether it's comminuted, the soft tissues around the area as well. So if you've got an elderly patient with really poor soft tissues, really thin skin, or diabetic patient, you kind of have to think about whether you want to go for plates and screws. But these are 2 x-rays. So on the left, you can see it's a distal third tibial fracture with a fibular fracture, and this patient has had some plates and screws put in, whereas on the right side, it's a mid-shaft fracture, and this patient's had a nail. Any questions on tib-fib fractures?
Are the fibular fracture, are they usually just left? Or
Yeah, they usually
as well.
Yeah, they usually are. So if you look at this image on the right, where my cursor is, your main weight-bearing bone is your tibia. Okay. Once you bring everything out to length, the fibula, as you can see here, will reduce, and it will heal. So most of the time you don't need to fix those. You start thinking about fixing these. For example, on the left, if you're worried about sort of ligamentous damage further down the ankle when you're heading towards the ankle joint, or if it's open, then yeah, you would. But usually, once you've reduced the tibia, the fibula will reduce as well.
Is the classification system called Shasta?
It is for tibial plateaus, yeah. So tibial plateaus, you can't, it's kind of missing on here, but if you just follow my cursor, this x-ray on the right is actually missing most of the knee, but your tibial plateau, so you can see, if you follow my cursor, you can see the joint space there. So any fractures along that plateau extending into the metatarsus, you would describe it using this Schatzker classification. Yeah. Good. Okay. Distal radius fractures. So distal radius fractures most commonly is a Fuchs injury, meaning that they've had a fall on an outstretched hand. You most commonly see this in elderly ladies. And I'm sure most of you have seen distal radius fractures. So on examination, usually it's a deformed wrist. The wrist is not looking right at all. It's painful. It's very swollen. Same principle again. Go through your basic assessment, A to E. Look for open and closed injuries. Examine the neurovascular status. So prepare your full time distally. You want to assess the nerves and whether they can move their fingers or not. You want to check for your radial pulse as well. And then obviously you'd want to then X-ray them. Can someone describe this X-ray to me, please?
Is it a fracture of the distal radius?
Yeah.
With volar angulation.
Okay. Yeah. Okay. So when you're talking about displacement, which part of the bone are you looking at? The proximal or the distal? So your fracture line's going through here where my cursor is, isn't it? So you're talking about this fragment, which is the distal, or the proximal fragment when you're talking about movement?
The distal.
Yeah, exactly. So this distal bit of the radius has moved dorsally. Does anybody know the name of this type of fracture? Extra-articular dorsal displacement.
Is it Colles fracture?
Yeah, Colles fracture. Good. So what's this one? Extra-articular. Well, can argue maybe intra-articular, but we'll assume it's extra-articular with volar displacement. So the opposite way around.
Is that a Smith's?
Yeah, Smith's. Excellent. And then this one. So this one on the left, intra-articular with volar displacement. What's the name for that type of fracture?
Barton's?
Yeah, so intra-articular fractures of this radius are called Barton's. They can split into volar Barton or dorsal Barton. So this is a volar Barton because your distal fragment's gone volar. On the right side, your distal fragment's gone dorsal. So yeah, Barton's good. So management of distal radius fractures. You want to, as with any fracture, restore the anatomy, and you want the patient to regain their function. Okay, so they can start moving their wrist again eventually. That is the aim of management. So initially, your initial management will be closed reduction. Okay, now this can be done under sometimes some simple pain relief. So little old ladies are actually very tolerant and they're very, very good, and you can just give them a bit of morphine and they'll tolerate you pulling their wrist. Other people are not. So in that case, you can give them some Entonox, or you can give them a block, either a hematoma block, which is over the dorsal aspect of the wrist, and then do the opposite of what you see on the X-ray. Okay, put them into a back slab. The reason you put them into a back slab is to allow for swelling. Re-examine the neurovascular status and repeat the X-ray. So whenever you intervene with a broken leg or arm, broken limb, you always repeat an X-ray. Distal radiuses can be managed conservatively if they're not massively displaced, if the joint line is looking okay, if they haven't lost too much height, or they're just very old and frail, they're not a surgical candidate, you can just treat them in a back slab and it will heal. If you're not happy with the reduction, or it's an intra-articular fracture, so if it's a Barton fracture, volar or dorsal, you would go down the fixation route because you want to restore the joint line, hence restoring the function. So there's a few examples of fixations. So if you're on my cursor, so in the top left-hand corner, this is an extra-articular distal radius fracture, and what the person's done, they've fixed it with some plates and screws. So they've restored the height. There's no more angulation, and things are starting to heal. On the left, you can use K-wires. I don't really see these being used very often, and they're more commonly used in children. And Adults can be an option, but not very common. We just go straight for an open reduction tone fixation with a plate. And down here is a special kind of external fixation. Again, very rarely see these. You would only really want to externally fixate a radius if the patient's very unwell, a major trauma, open fracture, and you just want to stabilize whilst other parts of the body are being stabilized that are more important, like the head, the heart, the lungs, the abdomen. Any questions on distal radius fractures? Okay. So we'll very quickly touch upon scaphoid fractures. Now, I've given you a bit of a clue here with this picture of blood supply. What is special about a scaphoid?
If you fracture it, it can cause avascular necrosis.
Yeah, and why can it cause avascular necrosis?
Is it due to its dual blood supply, or it's got a branch off the radial?
Yeah, so it's sort of like a retrograde. It's a retrograde blood supply. So if you fracture particularly through the waist of the scaphoid, a bit like the head of the femur, you're at risk of disrupting all these little vessels, and then as a result, you get avascular necrosis of the scaphoid. So that's what's special about the scaphoid. So how do people fracture these? Again, quite similar to distal radiuses, is fall into an outstretched hand. And they typically complain of pain in the anatomical snuff box. Either they have pain there, or when you examine them in the anatomical snuff box, they're finding it quite painful. They may have some pain in their wrist if there's a distal radius going on as well, or any other injuries in the wrist, but usually it's pain at the bottom of the thumb in the anatomical snuff box. Management. So if it's relatively undisplaced, you can manage these with just a special cast. So this is called a thumb spiker cast, this yellow cast, where you just immobilize that thumb completely. With displaced fractures, you'd want to fix those and reduce those. So here on the left, you can see a displaced scaphoid fracture. You can see this fracture gap here, which is not acceptable, and this patient will develop avascular necrosis. So you want to reduce that and reduce the risk of AVN by fixing it. So what they've done here is just put a cannulated screw through. That's literally scaphoids in a nutshell. Any questions? Okay, so moving on to humerus fractures, proximal humerus fractures. I was going to ask you questions on this, but I've given the answers away already. So proximal humeral fractures, again, these fractures are more common in sort of elderly people. Simple trip and fall. They usually have osteoporotic bone, and as a result, they fracture their proximal humerus. And they can fracture in any place of the proximal humerus. So if I go back a slide. They can fracture on the surgical neck, which is the most common place to fracture it, or along the anatomical neck, or sometimes the humeral head itself. If you fracture along the surgical neck, what you do need to test for this patient is the axillary nerve. What tests can you do to test for the axillary nerve? I mean, I've literally just put it there, haven't I? So they lose sensation over their regimental patch, the deltoid patch, which is your patch here, and the abduction is limited, and they can't shrug their shoulders, so their deltoid is not working very well either. Majority of the time with proximal humerus fractures, they can be managed conservatively, and most elderly patients can be managed conservatively unless they're very active or it's massively displaced or causing them huge amounts of pain despite conservative management. So you just manage them with a collar and cuff and let gravity take over, and these fractures will heal well. If a patient's young, or if the fracture is in a few parts, you would opt down the open reduction tunnel fixation route, which is essentially a plate going down the side of the humerus and a few screws going into the head of the humerus, and everything's nicely reduced. If there's a fracture dislocation, or it's just completely smashed to the point where you cannot reconstruct this humeral head, then the patient may need an arthroplasty. But the majority of the time, you either manage them conservatively or you fix them on plate and screws. Humeral shaft fracture, so below the proximal humerus. These fractures can either occur in elderly people who have not very good bone, simple trip and fall, or high energy. Okay. Majority of the time, again with proximal humeruses, very similar. You can manage these in the collar and cuff and manage them conservatively, and it will heal absolutely fine. You only really go down the surgical route if it's very displaced, if it's very shortened, or you have a neurovascular injury. Okay, so the main nerve you're worried about here is your radial nerve. So your radial nerve spirals around, goes down. Okay, and sometimes they can get trapped in the fracture site and they get radial nerve palsy or radial or unable to extend, etc. So in those cases, you would want to go ahead and fix them. And with humeral shaft fractures, you can either fix them same as the femur with a nail or plating screws.
Hi, Ms. Halliday. Can I just mention something for all the audience about this entire lecture? Yeah. I just want to remind especially the students is please don't look at all these slides and panic, that you need to know the nitty-gritty of every single fracture and the management of it. As long as you understand the principles of 4 Rs and you can sensibly talk about fractures, especially hip fractures and ankle fractures, that's really the most that's expected of you by the time you graduate. And as long as you know that there are some fractures that you can treat non-surgically, some that you treat surgically, and the decision is based on higher specialty opinion, that's a sound answer. The things that you cannot ever miss are things like the risk of compartment syndrome, the risk for avascular necrosis to a femoral head, for example. Those are really the unforgivable things. Most of the things are actually simpler, and what we are trying to teach you here is that there are several treatment options for each different fracture, and hopefully you'll take something away from all of this. But there's one thing that you want to stick to at the end is the 4 Rs of fracture management. I'll let Maryam carry on.
Thanks, Khaled. Yeah, Khaled's absolutely right. Don't be daunted by all the information that I'm giving you. It's just taking away basic principles. Any questions on who? Yeah,
oh yeah, sorry. I went to another talk and they said that sometimes with proximal humerus fractures, you can actually get bruising that's kind of migrated a bit more distally down the arm. Is that something you've come across? Is that common? Or? Okay.
Absolutely, and the bruising can look quite aggressive, actually. It's usually the whole shoulder, and it does sort of travel down the arm, and people do get very shocked by that, but it's very normal.
Okay, thank you.
Okay. Very quickly moving on to clavicle fractures. So clavicle fractures are sustained either through a fall or direct impact. The main things you want to really look at is for open injuries or skin tenting. What I mean by skin tenting is if you look at where my cursor is, the top X-ray, if this part of bone or that part of bone is putting pressure on the overlying skin to the point where you can actually see it, and there's bruising and you think there's skin compromise, for an orthopedic surgeon, that would mean that patient needs an operation to take the pressure off the skin, okay, and prevent it from turning into an open fracture. That's the main thing to take away for clavicle examination. Otherwise, the management is the same like any other fracture. Majority of the time, they can be managed conservatively in a sling, and it will heal absolutely fine. If it's an open fracture or it's massively displaced, the two bones are not touching or anywhere near each other, then you would go down the surgical route. Pediatrics. So with pediatric fractures, it's exactly the same principles. You go through your 4 Rs of resuscitate, reduce, restrict, and rehabilitate. What is different with pediatric fractures is pediatric fractures are difficult to reduce in a non-theatre setting because the patients are very young and they need higher analgesic requirements or sedation or even a GA. Okay, so usually they are done in theatre. I'll go through Salter-Harris in a second. The other thing with pediatric fractures is that children heal a lot faster than adults. Okay, and whenever you see a child with a fracture, always in the back of your mind, think of non-accidental injury. Obviously, you just take the history into consideration, where the fracture is, and liaise with the paediatric team if you're concerned. Supracondylar fractures are the most common paediatric fractures in children. And most commonly, they fall onto an outstretched hand, so a fusion injury, and extend and sort of hyperextend their elbow. They're usually closed, very rarely they're open, but again, you go through your same principles again of your 4 R's, basic history and basic examination. So this is the Gartland classification. This is the classification we use to determine what type of management a patient would need for a supracondylar fracture. So very briefly, in a nutshell, there are 3 types, 1, 2, 3. And essentially what you're looking at is how displaced is the distal humerus. And the line that you follow, which is this red line that you can see on these x-rays, is the anterior humeral line. And in a normal x-ray, this anterior humeral line, if you follow my cursor, will bisect the capitellum, okay? So if you see an x-ray like this, and you're not sure, just draw an anterior humeral line and see whether it bisects the capitellum. If it doesn't, it's most likely a supracondylar fracture. And then you can then determine if it's a 1, 2, or 3. So type 1, it's undisplaced. Type 2, there's displacement, but the posterior cortex is still intact. And then type 3, the 2 bones have just moved completely away from each other, so complete displacement. And these 3 types do determine our management. Can anyone tell me what, in your examination, there are a few important things that you do need to examine. What is the most important thing you need to examine for a supracondylar fracture? Anyone?
The arterial flow.
Yeah, so
Brachial
yeah.
artery.
Yeah, good, good. So brachial artery is at risk, particularly with a completely displaced fracture. What else? What else do you have around that area, around the elbow? Some important structures. You have some nerves. Does anybody know which nerves?
Radial.
Yeah, right. Good. Yeah, radial. Anything else?
The ulnar near the medial epicondyle.
Your ulnar and your median nerve. Okay. And the most common structure to be damaged, if damage was to occur, is the median nerve, in particular the anterior interosseous branch. Can anyone tell me how you assess for the anterior interosseous branch?
Is it sensation on the forearm?
You can test for sensation, but there's a specific test that you would do particularly for that branch. Remember, this is a child as well. So what movement can you get them to do? So anterior interosseous nerve supplies your deep flexors. Has anyone heard of the OK sign? Ask them to do an OK. Yeah, so that's testing your FPL and your radial part of your FDP, and that's what your anterior interosseous nerve supplies. Okay, so just ask them to do an OK sign. So again, these are just some x-rays of supracondylar fractures. So if you look on the right here, the yellow line is the anterior humeral line. It's not completely going to the capitellum, but it is touching it. If you look at this x-ray, if you follow my cursor, that's just on the edge there. Oh, sorry. And then obviously on the x-ray on the left, it's complete displacement. So with supracondylar fractures, as with any other fracture, if it's millimeter space or underspaced, you can probably just manage them conservatively in a back slab, and then we follow them up in clinic and continue from there. If there is some displacement or complete displacement, you must examine the neurovascular status, and then we need to be aware of this because this can very quickly turn into an emergency. And the reason why you can tend to emergency is disruption of the blood supply. So as you mentioned, the brachial artery. So if on your neurovascular examination, the patient has a pale hand and a pulseless hand, you cannot feel the radial pulse, it's cold and it's pale, that is an emergency. That fracture needs to be reduced, so we need to be aware of that. And this is one of the ways we can fix it. You can either fix it with some wires or in some rare cases, plates and screws, but usually wires. We're approaching the end. So lastly, Salter-Harris fractures. Can anyone describe this X-ray to me? So just describe what you see. So this is just a bit of context. A 6-year-old boy who fell off some monkey bars, landed on an outstretched hand. Anyone? Okay. So it's a distal radius fracture. Yep. So it's an AP and a lateral of a child's wrist. Why do we know it's a child's wrist? Well, they have growth plates. You can see their growth plates, and there's displacement. So you look at the dorsal fragment here. There's dorsal displacement of their distal radius, and the fracture line has gone through growth plate. Okay, so it's a Salter-Harris fracture of the distal radius. It's actually a type 2, and I'll go through in a second what I mean by type 2. So Salter-Harris classification. So this basically describes the relationship between the fracture and the growth plate. So the growth plate is the blue line on all these fractures. Okay, where my cursor is, it's the blue line. And there's 6, but essentially 5 different types of Salter-Harrises, and this is the way I remember them. This is the way I think most people remember them. Type 1, as you spell out Salter, 1, 2, 3, 4, 5. S stands for straight across, so the fracture line is going straight through the growth plate. Type 2, the fracture line is going above the growth plate, so into the proximal fragment. Type 3, the fracture line is going below the growth plate, so into the distal fragment. Type 4 is going through all fragments. It's going through the proximal bone, through the growth plate, through the distal bone. And then type 5 is a crush injury of the growth plate. So I'll show you some x-rays just to kind of appreciate what I mean. So type 1 is S, so straight through. These are very easily missed, and don't worry if you've missed them, because I'm pretty sure I've missed a few of these during my early years. So essentially what you see is, so this is a child's x-ray. You can see this growth plate here. Just follow my cursor. This is the growth plate, but here there's a little bit of a widening, and that's where you suspect that the fracture line has gone through the growth plate. Essentially, just reduce these, restrict them, put them into a slab, and they'll heal fine. We don't really need to do anything about it. Type 2 is gone into the proximal fragment. So again, if you follow my cursor, this is the growth plate, and there's your little faint fracture line there. Okay. And type 2 is the most common type of Salter-Harris fracture. Same management as type 1, usually just reduce them, restrict the movement, and eventually you'll start rehabilitation. Type 4. So type 4 is a fracture line that's gone below the growth plate into the distal aspect of the bone. And these are usually intra-articular fractures. Type 3, you treat these patients like adult intra-articular fractures. Intra-articular fractures mean fractures into the joint. Any fractures into the joint need to be reduced anatomically. Okay, so that usually means surgery. But otherwise, your principles are the same: resuscitate, reduce, restrict, and rehabilitate. And type 4, if you follow my cursor, it's gone through all three parts: proximal bone, growth plate, distal bone. And these most definitely need some sort of fixation. So those are most fractures in a nutshell. What you do need to be aware of are complications of fractures. And I think this table is very, very nice in terms of splitting complications. So when you're asked to describe complications, you split it into systemic complications, that's overall body, and then local complications, particularly for that limb. And then you can further subdivide into early and late. I would strongly advise to either take a picture or a screenshot of this, because it's a very, very useful slide to know. Last but not least, just a few pointers.
Can you go back for 1 second?
Yeah, of course. On the complications.
Yeah, I got the screenshot. Thanks.
Okay, fine.
Maryam, just before we get to the end, do you mind just coming back to, you know, your Salter-Harris classification slide?
Yeah.
And the only reason I'm sort of going to labor that point a bit more is this is an absolute expectation from you at undergraduate level. At postgraduate level, it's an absolute given. One thing to remember is if you turn these bones upside down, one can get massively confused as to what's above, what's below, what's through. The whole thing about classification is classification systems are made to predict either severity of the injury or severity of the outcome. The one thing that Salter did quite well is he's in a very chronological order, gone through what's a good one and what's the worst one. The type 6 is neither here nor there. If you just stick to up till type 5, that kind of helps you. If you just think about it, some people remember that as a slip rather than straight across as well. And that's not really a bad thing. And this whole thing above and below, I think an easier way, I mean, I am not a big fan of mnemonics, but an easier way to remember it, if a fracture line comes into the metaphysis, which is not into the joint, that surely has got to be a better thing to have. And that's another way to try remembering it, that, you know, the type 2 is not so bad, it's not in the joint. Type 3 is in the joint, is getting worse now. Type 4 is through, so above and below is surely worse. You've got 3 different zones, the epiphysis, the physis, and the metaphysis that's involved. And type 5 is a crush injury, okay? You crush something and it dies. And the whole reason this classification system was made was it helps you decide, 1, how severe the injury is, number 2, how aggressive your treatment needs to be, and 3, what are the ramifications of this in the long run. There was no extra of the type 5 because type 5 is extremely difficult to see. And the reason for that is if you get a type 5, you can't reduce it, you can't restrict it. And the only way you find out that this patient actually had a type 5 fracture is when they come to you in 5 years' time at the age of 16, when they sustain the injury at the age of 11, and their bone hasn't grown at all, okay? And it can happen to you where you're a GP and you didn't have an interest in orthopedics, we didn't manage to inspire you today. And you're a GP and you've got a patient whose mother's come in and said, for the last 2 years, my child's wrist has not grown one bit. What do I do? That's what you know you've got to do from these lectures. You just got to refer on to pediatric orthopedics, because we can lengthen limbs and we can shorten limbs and we can change the angulation. We can do all that kind of stuff. We've got clever colleagues that can do that for us. The 1 and 2, we know that they're right in the beginning of the spectrum, so they're not too bad. And 3, when it starts to go into the joint, like as Maryam said, anything that's in the joint, you've got to treat it. Okay, and 4 is certainly in the joint and beyond it. So again, you've got to treat it. So you're going for non-operative to more aggressive operative to, oh shit, right, we're at the end of spectrum and the damage has already occurred. We need to do something about it now. So that's the spectrum of it. And that's what the importance of Salter-Harris classification is. And once this lecture is finished, I would recommend that you guys at least look at some x-rays above and below. So, you know, when you do x-rays of an upper limb, that your epiphysis is actually, you know, towards the sky. Right? When you do an x-ray of a lower limb, your epiphysis, meaning, you know, the joint, is towards the floor. And I know how many medical students that I've examined formally at university level who get this absolutely wrong. And they say the silliest thing, the stupidest thing, just because they just remembered an acronym. Okay, so there's only what, 10 students here. If we can get at least 6 out of 10 of you to remember this today, we've at least done half our job, and the other job is getting you to remember the 4 R's.
Excellent. Thank you. Yeah. Right. just a few other pointers, just to be aware of. Timings of healing, average timing. So bone formation, new bone formation is in about 6 weeks. Full fracture healing is in about 12 weeks. It does depend on what kind of bone it is. So obviously the lower limb, the femur, takes a lot longer than, say, the wrist. And as I mentioned before, children's bone do heal a lot quicker than adult bone. So these are sort of just rough timings. Whenever you do an intervention to a bone, whether that's putting on a cast or sometimes a type of fixation, if you don't use x-rays, for example, joint replacement, you do need to repeat an x-ray, just make sure you haven't made the bone worse. Okay. And three important bones that are at risk of avascular necrosis, which I think is really important to know, is the head of femur, which we've discussed because of their retrograde blood supply, the scaphoid, which we've discussed, and the other one is the neck of Taylor. So you don't need to know this in too much detail, but as long as you're aware, there's three parts in the body that are at risk of avascular necrosis. That bit's important. But otherwise, the main thing to take from this is, as Carl mentioned, the Salter Harris, recognizing hip fractures, intracapsular, extracapsular, and the most important thing are the 4 R's. Okay, so just as a quick recap, resuscitate all your patients, go through your A to E, manage the patient as a whole, not just the bone. Reduce that fracture, whether you put it into a slab, whether you splint it, whether you put it into traction, reduce that fracture, and that will restrict movement at the fracture site as well, at least conservatively, whilst we're planning for fixation if needed, and then rehabilitation is the last stage. Any questions?